Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Great. Thanks, Brian. Nice to be back. Good to see some faces I remember from prior echoes. So let's talk about REPRIEVE. And the subtext here is practice changing or practice affirming. And you'll hear what my answer to that is at the end. Here are my disclosures, none particularly relevant to this talk. And then this disclaimer and data considerations. So I'll start by saying that we all know that people with HIV have a higher risk of cardiovascular disease. And this is a graphic that we put together in a review we did on cardiovascular disease in women with HIV, showing that that risk is different for men and women. It seems to be the HIV-specific risk, or the risk that's associated with HIV infection after controlling for all sorts of other possible confounders, tends to be higher in women than in men. But on average, over the whole population, maybe we say 1.5 to 2-fold higher risk of cardiovascular events. And not just atherosclerotic cardiovascular events like myocardial infarction and stroke, but also heart failure, whether that's heart failure with reduced ejection fraction, but also heart failure with preserved ejection fraction. And there are other cardiovascular diseases as well that seem to be increased in people with HIV. And the way we've kind of thought about it over the last couple decades is that while maybe early on we thought it was antiretroviral therapy, our current thinking is that most antiretroviral therapy is not associated with increased risk of cardiovascular disease, but rather it's the traditional risk factors and possibly this residual inflammation and immune activation that persists despite effective antiretroviral therapy that may be driving cardiovascular disease and other non-AIDS comorbidities in people with HIV. So I wanted to provide a bit more background on how the REPRIEVE study kind of came about. And you may remember, for those of you who were practicing back 15 years ago, 20 years ago, the Jupiter study, which was a study of rosuvastatin to prevent vascular events in men and women with elevated CRP. The idea being that people with underlying inflammation might have more of a benefit of statin therapies because of kind of this anti-inflammatory or pleiotropic effect of statins. So we'll remember that the Jupiter study showed an LDL cholesterol reduction of 50% with rosuvastatin. I believe it was 20 or 40, reduced LDL by 50%, hsCRP by 37%, and CVD events by 44%. So this study kind of was the start of Paul Ritker's trying to prove that inflammation can be targeted in reducing atherosclerotic cardiovascular events. Around that time, one of my mentors at Case Western, where I was previously, Dr. Grace McCumsey, came up with the idea of, well, let's do this in people with HIV. And so she wrote a grant, an R01, that looked at people with HIV, giving them rosuvastatin or placebo, and following them over 96 weeks for a variety of other kind of surrogate measures of inflammation and cardiovascular disease. Now, we weren't powered in this study to look at cardiovascular events, but you can see that certain markers of inflammation that we've heard about in the past, soluble CD14, at the time, CD4 and CD8 T cell activation is measured by 38 and DR on a flow cytometry. They both went down with rosuvastatin over this 2-year period. And then I was kind of leading the carotid IMT measurements as part of the study as a cardiology fellow. And we published those results in AIDS showing that rosuvastatin really arrested progression of the carotid intima media thickness, whereas in placebo, there was kind of an expected progression of carotid intima media thickness over time. So again, I was the one who came up with the study acronym, Saturn HIV, after the Jupiter study. So with that, then, around the same time, the 2018 cholesterol guidelines came out, which proposed that people with borderline risk or intermediate risk, as calculated by a 10-year ASCVD risk calculator, as many of you are familiar with the pooled cohort equations calculator, that for these people that a risk discussion should be had, and that if there are risk enhancers present, that should push us towards recommending for our patients statin therapy. And one of those risk enhancers that was specifically named out was HIV. And so I would argue that even as far back as 2018, there is some guidelines to suggest that we should be treating patients with a ASCVD risk score greater than 5% with statin therapy if it is in line with their goals of care and after a patient-centered discussion on decision-making. So, the REPRIEVE trial was already underway in terms of the planning for REPRIEVE when those cholesterol guidelines came out. But just to remind everyone, the high-level results were published in August, showing a 35% reduction in the combined endpoint of MACE, or major adverse cardiovascular events. And so we're going to kind of drill down a little bit more into those results and think about the implications of those. I'll just put it here, we're going to come back to this, but if you look at the ASCVD risk score, you can see that people were allowed to enroll in REPRIEVE even with ASCVD risk scores greater than 5%, as long as their LDL cholesterol level was not above a certain threshold, and we'll go over that. But you can see that the vast majority of the events in REPRIEVE happen in that group above 5%. And so also going to come back to that. So here are the inclusion and exclusion criteria. This is people living with HIV, age 40 to 75, with a 10-year risk score less than 15%. And that is a threshold which was changed over the course of the initial enrollment. Originally, it was more strict, but they kind of loosened it up and then said if you had a fasting LDL cholesterol that was under a certain level, you could, if you're 7.5 to 10%, you had to have a cholesterol less than 160, 10 to 15 less than 130. And anyone with a cholesterol less than 70 was eligible regardless of their 10-year ASCVD risk. And diabetes was excluded because, again, it was pretty clear in the guidelines that people with diabetes benefit from statins. And then I'll just highlight again that this was stopped early by the DSMB in March, so about 10 months ago now, with the median follow-up over these 7-8 years or so of an average of 5.1 years of median follow-up. And these are the characteristics. Again, had about 3,900 in each group. The pitavastatin group, and balanced obviously in this randomized controlled trial, with about 50% of them coming from high-income countries. But as you may know, there are ACTG sites around the world, and many of our Latin American colleagues were very good at enrolling. In sub-Saharan Africa, I do a lot of work with the JCRC in Uganda. They were particularly good enrollers, such that you can see a really interesting global distribution of participants. The median age was 50, and the distribution shown here with 69% or so being male. Coming back to this again, the ASCVD risk score, the median score was only 4.5%. And so most of the participants in the trial really had this risk score less than 5%, even though, as you remember, most of the events will end up happening in those who have higher cardiovascular risk. So, and there were, a considerable number, 563 total, with ASCVD risk score greater than 10. Here are the Kaplan-Meier curves, just showing that the curves separate relatively early on, after a year or so, and you can see a clear benefit of pitavastatin over placebo. Here's that graphic from the first slide. Again, 35% overall reduction with a 95% confidence interval shown there. And again, by ASCVD risk score, it seems to be relatively consistent across the group. So it seems like the magnitude of the relative risk reduction is not related to the ASCVD risk score per se. What is very interesting is that almost all of the events came from high-income countries. And you can see that the effect size thus reflects the overall effect size. And if you look at sub-Saharan Africa, again, where I do a lot of my work and think a lot about cardiovascular risk, the number of events per 1,000 person years was extremely, extremely low. Right. And so I think this is relevant as we consider whether or not statins are going to be something we're going to implement all over the world, or just in certain higher risk populations. And obviously the confidence intervals are really wide because of the small number of events. What about sex? If you look at females and males, the effect size seems to be very similar, almost identical actually. And so that's good news, knowing that females may be at higher risk, so they will perhaps equally benefit from statins. But what was interesting is that these data were presented by Markella Zaney at the IAS conference last year, that if you look at the placebo group, the event rates were actually higher in women than in men, which again reflects that same graphic that I showed in my very first slide, and are probably higher than what would be predicted by your ASCVD risk score. So if you have an ASCVD risk score of 5 to 10, you would think, 5 to 10 events per 1,000 person years. In this case, for women, you're seeing 15 events per 1,000 person years. So again, about a twofold increased risk of what you would expect by the ASCVD risk calculator. Whereas in this, in the lower risk groups, that the magnitude of that kind of under prediction of risk is not quite as strong. From a safety standpoint, Jupiter showed that rosuvastatin is associated with an increased risk of diabetes, and the risk ratio here, about a 35% increased risk, is similar to what has been seen in other high-dose statin trials. Similarly, other sorts of adverse events were not out of the range of what has been seen in other statin trials. So this is an important graphic that both Steve and Pam, who are the co-PIs of this study, presenting these data, like to show. It's a meta-regression of cholesterol treatment trials of various kinds of cholesterol drugs, not just statins, but things like ezetimibe, like the Improve It trial, or the PCSK9 inhibitors like Fourier and Odyssey. If you put REPRIEVE on the graph, the magnitude of reduction in LDL cholesterol and the reduction in major adverse vascular events is such that you kind of have outsized proportion of the reduction in events for the magnitude of LDL cholesterol, right? So anything above this line is kind of, you're having a more of a reduction in events than you would expect given the reduction in cholesterol, and anything below the line is kind of the opposite. So you see that REPRIEVE kind of finds itself up here with Jupiter, which I showed at the beginning. Again, Jupiter was a study of people with underlying high levels of inflammation as measured by hsCRP. So the thought is maybe that statins are having some sort of extra benefit in people with a chronic underlying inflammation. But, the magnitude of the 95%, confidence interval is quite broad. So, who knows, maybe this was by chance that it's so far above the line. So for me, some take-home points, and I'll go back to the 2018 cholesterol guidelines and actually the scientific statement that I was part of for the American Heart Association, which really has recommended for many years that we treat people with HIV as having an increased risk, and so using it as a risk enhancer, and really in general treating anybody with an ASCVD risk score greater than 5% if they are willing to consider a statin. So for me, this is not really practice changing, it's practice affirming. The event rates in the group that was less than 5% in REPRIEVE were so low that the number needed to treat is quite high. It's in the 350 persons range to prevent one event over 5 years, I believe. So it's clearly not as much of an absolute benefit in patients who have an ASCVD risk score less than 5%. But statins are safe, and what I like about REPRIEVE is that fortunately it was a positive trial, that there won't be negative press about it, and that for people who maybe didn't have the practice of generally recommending statins for people with kind of intermediate risk will feel more comfortable about doing so now. I think that there clearly are efforts to revise clinical practice guidelines. I've been asked to participate in an American Heart Association effort along those lines. But I think it's unlikely, and this is my personal opinion, that we would recommend statins for everybody, particularly for those with a low ASCVD risk score less than 5%, even though those participants were in the REPRIEVE trial. For populations with a lower overall ASCVD risk score, as I showed, for example, people in sub-Saharan Africa, I think implementation of statin therapy is probably a lower priority compared to things like trying to control hypertension, which is a much more significant driver of risk in that population compared to cholesterol. But you may have seen that in South Asians, for example, there may be an increased risk overall, and that it may be a higher priority to implement statin therapy in those populations.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.